So John, we've seen these remarkable, new targeted therapies come in, along with, again, role of, modified antibodies like obinutuzumab, and now we have to think, again, with a discussion with low-grade lymphomas, about what we do at the time of relapse and how do we sequence when we have actually so many options at the table. So you want to start talking about, first, what are the risk factors for relapse, and then how would we look at, for example, the role of Ibrutinib or other therapies in the relapse setting?
Mm-hmm. No, that's. I think the risk factors at the time of relapse are pretty much the same as at diagnosis. So the IGVH unmutated patients, the 11Qs, the 17Ps, the complex karyotype, and the time of remission. But those are going to be risk factors, and so that we factor in. But generally the same principles hold for the most part. Particularly with Ibrutinib, if you have a low risk feature in the setting of relapse, as long as you tolerate Ibrutinib, it's extremely unlikely that you're going to progress on Ibrutinib. If you have a 17P or complex karyotype, and Susan O'Brien will be presenting updated data from the initial phase 2 study, only about 30% or less of those patients at 5 years are still in remission and on therapy. There's a subset that have gone off for alternative reasons, but a good number of those patients progress. There's registry data, and I don't like registry data, but it gets down to the granularity of real patients and what's done in the community. And Dr. Mato from Penn sort of looked at patients receiving different targeted therapies and who does best. And it's interesting, and I'll be interested on Michael's take. It sort of confirms, I think, clinically, there's not a randomized study comparing Ibrutinib to venetoclax versus idelalisib in the relapsed patient population, and I have my own bias, having done a lot of work with Ibrutinib. But when you look, when you compare across the studies, the durability, all three work very well in the relapse setting, all genetic groups, but the durability with Ibrutinib appears better. Again, comparing across phase 2 studies with all of the caveats of that and personal academic biases. And say Dr. Mato's study was interesting, and it sort of reproduced that in the real world, showing that that people tend to stay on that longer. And so, I mean, we've treated a lot of patients at OSU with Ibrutinib, myself, as I say, in particular. But I'd be interested in Michael's opinion of sort of how he sequences, because in general, for the relapse patient, my first choice, if there's not a contraindication to Ibrutinib, is to use Ibrutinib.
I agree totally with that. I think that the early phases of treatment, the results are so good and the patients feel so well that everyone's happy. It's just the question is not being raised is, do you need to continue it all the time? And the other question that we're trying to address is, do you need the full dose all the time? Because when you give the Ibrutinib, the covalent binding of Ibrutinib with the BTK is so tight. And most of the BTK will be in the CLL cells, so that if the CLL tumor burden goes down, do you need the same amount? And if you're giving them the same amount, do you get to the point where there's free drug floating around? And we know that certainly there's off-target effects on different enzymes that were presented again this morning, that Acalabrutinib, which is under investigation, and unfortunately chlorambucil arm is in a 3-way randomized trial at the present time.
I think it's chlorambucil obinutuzumab.
Yes, but chlorambucil's still there.
Yes, but that's better than chlorambucil alone.
It refuses to die. Anyway, I think the situation is that we fell in love with these drugs so much that we stopped investigating them. And I think that one of the very good presentations so far in the meeting was with Jennifer Wyack talking about the long-term outcomes, how many progress, how many don't, of those that do progress, how many of them have mutations in the BTK, and what the consequences are, and the change in the biology that gets induced by prolonged exposure. And then the resistant cells with mutations behave differently. And John and his group have done a spectacular job in documenting the long-term sequential impact of the drug in their patients.